3, 2, 1.
Yes, sir. 3, 2, 1. You can.
First of all, a warm welcome for Bayer ISEC meeting. Today we have our speaker, Dr. Sriram Charan sir. Sir is working as a video retina consultant at Ananda Institute. With this, I'm handing over the session to you, sir. Sir, over to you, sir.
Uh, Good evening. I thank Bayer for giving me this opportunity. So today I will be discussing the evolving role of aflibercept in the management of PCV or polypoidal choroidal vasculopathy, with emphasis on the Asia Pacific 2025 recommendations, major clinical trials, durability data, and comparisons with newer anti-VEGF agents. So PCV remains highly prevalent in Asian population and it continues to pose a diagnostic and therapeutic challenges. Recent evidence increasingly supports anti-VEGF monotherapy, particularly aflibercept, as highly effective treatment option. So, what is PCV? Actually, then how is it different from our wet AMD or choroidal neovascular membrane? So, this PCV is actually the location of the polyp is under the subretinal layer, sub-RP layer, where there is a pachychoroid. That is the we know that choroid has a vascular layer, which is an inner vascular layer and an outer vascular layer. So these polyps arise from the inner vascular layer and they have typically a leaking blood vessel wall which will leave behind the subretinal either a serous PED or a it can bleed and it can cause a subretinal hemorrhages as well. So what are the criteria to diagnose this PCV? So on OCT, if we see any a sub RPE ring-like lesion or any thumb-like PED, that is a thumb-like projections, which is ideally, these projections, when we do a histopathology, there lies the polyp. So, and when there is a double layer sign, that is because of the raised polyp, the vascular layer, the choriocapillaris layer will also have a enhancement. So, apart from the RPE enhancement, if we see a choriocapillaris enhancement, this is called as a double layer sign. And so if in OCT we see these signs, we can label it as a PCV. Or if we are not able to, if the OCT is not conclusive, we go for a fluorescein angiography or an ICG angiography, where invariably the blood vessel being the dye will be traveling through the blood vessels. So that will give us a diagnosis. And if there is a large submacular hemorrhage and an active extrafoveal polypoidal lesion, so these are the other major clinical findings which should point us towards the PCV rather than a CNV. CNV is just a network of abnormal vessels which will be under the RPE layer or in the choriocapillaris layer. So that can be differentiated from a PCV with the above said findings. So apart from this, ultimately when we see a diagnosis of PCV, what APVRS guidelines are suggesting is that the monotherapy of any anti-VEGF drug is actually helping in curbing the disease rather than the combination therapy or with a PDT. PDT is a photodynamic therapy. This actually is the ultimate treatment where the polyp, if we can locate the polyp and if it is extrafoveal and nothing like it, just ablating that polyp will definitely curb the disease. But the flip side of the PDT is the vision cannot be improved, and vision loss is more and when compared to the anti-VEGF monotherapy. So, but the anti-VEGFs are really doing a good job by decreasing the polyp, and also it is also helping in restoring some useful vision. And in some cases, we can even expect a better visual acuity when compared to PDT. And also it is a safe procedure. Taking an injection is definitely safer, and it is also painless procedure. And the PDT usually it takes time, But whereas injections, they just within a span of 5 to 10 seconds, you can give an injection. So these are all the pros and cons of the anti-VEGF versus PDT. So once we do an anti-VEGF monotherapy, we just need to monitor the treatment that I will be explaining in the further slides. So monotherapy with anti-VEGF is definitely effective in many cases and of PCV and can be used initially. So what is this slide mean? So what are the different anti-VEGFs available? We have aflibercept, brolucizumab, ranibizumab, and faricimab, newer drug that is a faricimab. So 95% expert consensus supported anti-VEGF monotherapy. Now the question comes, which one we have to select? So the KD value, what we are seeing here is the binding, it gives us the binding affinity for VEGF especially. So the lower the KD value indicates a stronger VEGF binding. So which is very much comparable here, and we obviously here aflibercept being the lowest, and that KD value that shows that it has a stronger VEGF binding. And there is one more advantage of this aflibercept. It is called as a fusion protein, and the aflibercept it has a binding affinity to VEGF-A, VEGF-B, and PIGF also. And the being a fusion protein, it acts like a decoy where it can bind the VEGF very strongly, and it is proven to have a better molecular dynamics which can curb the VEGF-A and PIGF. Whereas the brolucizumab, ranibizumab, and faricimab, they all have their own way of acting, but the main thing is VEGF binding capacity is more in aflibercept. So what does the early evidence support? In aflibercept, initially the studies demonstrated that PCV patients treated with aflibercept achieved visual gains comparable to typical neovascular AMD patients. That is a very significant change what we can bring about with anti-VEGFs when compared to PDT. That's what I was trying to explain in the previous slides. PDT visual gains are not the outcome. Why do we do PDT is to curb the disease, but subsequent curbing the disease and getting a visual gain you can expect with anti-VEGFs. So that's what, and when compared, and it is comparable to our counterpart, that is CNV. So that is something very important to note. So what is this PLANET study? It's a landmark trial. It was a multi-center randomized double-masked trial, which is compared with a sham. So patients initially received 3 monthly aflibercept injections, followed by either aflibercept monotherapy, or if in a case the disease is worsening, they have been offered with a aflibercept plus rescue PDT. So the primary question was, is PDT necessary in all the cases? Yeah, the PLANET study is giving us the answer. Anti-VEGF monotherapy, that is aflibercept monotherapy, is definitely superior. And at the end point of 52 weeks as a primary endpoint and 96 weeks as study endpoint, we can see that there is a definitely improvement of vision, and stability also is there in the vision, whatever, and disease also is definitely curbed at that point of time. So here the outcomes, if we can see, there is a mean increase of about 10 letter increase with mean injections of 8 injections in year 1 and 4 injections of year 2. We can expect about 10 to 11 letters improvement. That is what is the PLANET study is giving us. So here, if we see the Altair study, here what we are observing is the treatment regimen. So treat and extend regimen, if we use aflibercept as a treat and extend regimen, what is the result we are going to get? So the key message is here that visual gains were maintained through the 96 weeks in both PCV and not PCV patients. So what is treat and extend? We treat the patient with 3 monthly injections, and we extend the follow-up period. That is the patient coming us after for primary treatment of 3 injections, he will come about 4 weeks later. Then we extend the follow-up by 2 weeks. If there is any disease activity, we give an injection. If not, we just follow the patient and we observe during the follow-up, we observe for visual acuity, and if we observe any disease activity clinically and in form of OCT. Clinically, what we see is if any there is new submacular hemorrhage or a subretinal hemorrhage or any new PED which is popping up or any new serous detachments we are seeing, any subretinal fluid or an intraretinal fluid. In OCT, we observe those two things, that is the SRF or IRF and any new PED which is popping up. So, and now the treatment burden. See how many injections. If we see here, year on year, the number of injections are coming down with aflibercept, because aflibercept being a multi level action of this, not apart from VEGF-A, it is also binding to PIGF, and the binding capacity is more, affinity is more. So by these actions, we can have a number of injections also is lesser. So but at the same time we are also maintaining the vision, the visual outcomes are not compromised by just giving a lesser number of injections. Polyp regression is something which is very fascinating here. So one of the major strengths of aflibercept is its ability to reduce polyp regression. So historically only they believed that PDT was the one which was doing this polyp regression or polyp closure. However, because the polyp blood vessel wall is very fragile and it is leaking, so the advantage of aflibercept is it can penetrate deeper into the choroid level as well, so that it can bind the VEGF at the very endothelium level itself, and by that it is significantly reducing the polyp size. So that is a very interesting point of aflibercept. So when compared to the newer drug, that is the faricimab, so the Planet study and Salavin study, if we can compare, they both are, of course, they are individually, they are randomized controlled trials. It is not the cross trial comparisons. Sometimes it should not be interpreted. It should be interpreted very cautiously. But ultimately, what we want to see here is, surprisingly, aflibercept number of injections is only 12, and it is giving a good results when compared to the newer drug. So why the durability? If we see here, the real world study compared aflibercept with the faricimab, visual acuity improved significantly after loading doses. You see, even a newer drug is requiring a loading dose. When if we are getting a newer drug into the market, at least it should prevent the loading dose concept. But surprisingly, even they are advising for a loading dose. So if we see the same thing, when being time tested, aflibercept is doing a good job. So it is a better exudation control it is showing, and it is showing a greater rate of polyp regression. And also the clinically, if we see, aflibercept monotherapy is definitely sufficient, durable and effective when compared to PDT. So safety profile, more than 50% of patients were assigned to faricimab. Here, when compared to faricimab, it is definitely showing a better result. So head-to-head comparison in the real-world study also, it is showing that aflibercept and faricimab treatments are effective in reducing exudation and retinal thickness. But aflibercept being time tested, and it is being from many days before, when compared to faricimab, it is more likely to eliminate the exudative changes, improve the visual acuity, and also the polyp regression. So I would like to share a case of mine here. She's a 65-year-old female presented with diminution of vision in left eye, and her presenting visual acuity was 6 by 36. So here, if we can see the OCT, we can see a thumb-like projection, PED, and there is a double layer sign, and that PED is leaking, and it is showing a minimal IRF and SRF as well. So these are all features suggestive of PCV. So we started her on aflibercept loading dose. She received injection aflibercept, total of 7 injections between June 2022 and March 2026. So we can see that there is a regression of polyp, very significant regression of polyp, and there is a minimal IRF that was also coming down. And the last OCT, you can see that the IRF also has come down and the PED came down, and the visual acuity also has improved to 6/12. So aflibercept 2 milligrams efficacy and safety profile has been established across the many RCTs and is supported by over a decade of real world data as well. So more than 20,000 patients from more than 20 countries, they got treated with real world studies. So there is a very low rate of IOI. Practically, I never came across IOI in aflibercept, and the rate of endophthalmitis, it is comparable. It is in the real world. The most important thing is it is approved in total of 7 indications globally: BRVO, CRVO, DME, macular CNV, NAMD, and NVG, ROP as well. So definitely aflibercept I would advise in PCV, when especially in PCV cases, if you come across, because it is a time-tested drug and it is having a better affinity, and polyp regression also is there. So aflibercept definitely is a go-to drug when compared to the other drugs which are in the market. Thank you.
Thank you, sir. Thank you. Sir, we will wait 1-2 minutes, sir, actually, for any doubts are there from audience.
Sure, sure. Madam, in PCV, definitely. Yeah, PCV definitely loading dose is recommended, madam, when compared to PRN, because the polyp is very notorious. Because the polyp which we are seeing is only clinically, we are mapping it under the central 6 scans only. So practically speaking, if we see in many of the OCTs, they do only macular cube, that is about 3 by 3 only. So polyp, anatomically, the polyp is very large. It is not spanning only at 3 It can be up to 9 and even 12 If we can see an EDI OCT of 12 by 12, then that's why previously they used to do an ICGA, good ICGA or a good FA to map the polyp, so that the polyp extension is very, very at the larger area. So treating with only PRN may not be sufficient, and we may not be able to give the proper justification for the patient also. So the better to do a loading dose regimen than PRN in PCV. So my experience of PCV with PDT nowadays is actually very less, madam. And in private practice, we don't get to see these PDTs. But anti-VEGFs alone is definitely it is superior when compared to PDT, because PDT is literally we are ablating the retina, and that ablation is not just restricted to the polyp. It can extend even to the fovea or a subfoveal. Sometimes foveal and subfoveal regions, if they are involved, then gone. We will not get any vision back. So we can't get the vision back. So, but anti-VEGFs here are surprisingly, they are working very well. They are regressing the polyp, they are improving the vision, and that vision also is, see, sometimes PCV, if some useful vision, if we can give to the patient, that will be really good. Sometimes surprisingly, we are getting even 6/12, 6/9 vision. So why to deny that from patients? So definitely anti-VEGFs are superior when compared to PDT. Yes, as I said previously, if that polyp is really large and if it is not, sometimes they won't respond to the anti-VEGFs because of the many reasons, like if the vessel wall gets very tough, and if penetrability is less, and if the patient it's not responding, if already patient has taken some around 30-36 injections, it's still not responding, and if the polyp is in extrafoveal region, definitely PDT would help us. in ablating the polyp, nothing like it, because it is a final treatment. Once you ablate the polyp completely, then the disease is significantly reduced. I hope I was clear in my explanation.
Yes, sir. Hope I think there are no other questions from audience. Hope I think it's good to close, sir, this meeting. Once again, sir, thank you so much for your wonderful presentation. And thank you all the audience who is attending. I think this is the peak time, the middle of the week. But still you are sparing some time to learn something which is not learning earlier. So once again, thank you to all the audience.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Okay, sir, we are concluding the meeting. Okay.
Yes, yes. Good to close. Thank you.